Excellent. So it's interesting, when I did this, I wasn't thinking about capacity in the sense of human capacity, and that's a whole different talk, I suppose. My focus for today really is to talk about that challenging situation where we're just not sure people understand the implications of the decisions. And certainly for you guys working in case management, I think this is you're frequently tasked with trying to come up with that safe plan when we're not quite sure how much the patient's fully appreciating their circumstances. So what do we do about that? And just by way of background, I do practice in Vermont. I appreciate that we have people from all over New England on this call. And most of my comments specific to state law will focus predominantly on Vermont, but I'll try to bring in what I know about other states as well. So the goal for today really is just to start off with a case, and I think unpack that case and try to develop a better understanding and appreciation for this thing we call decision-making capacity, figure out from an ethics perspective, how do we navigate our obligations to respect patient autonomy while we're equally obligated to try to promote good choices and avoid harming the patients that we're working with. And what is that right balance that we need to strike in terms of that interrelationship that exists between risks that people are taking, their rights, and our responsibilities. And it's a complicated, it's not a binary kind of a process. And so I think it's really important to think about it from a lot of different dimensions. I do welcome you all to use the Q&A or whatever the process is to have this be more of an interactive conversation rather than just having to listen to me for this first session this morning. So I don't have any conflicts of interest. And I want to just start us off here with a case which probably would seem quite familiar to most of you. A 73-year-old widow. She lives alone independently in her own home. She arrived in the ED at the hospital with an altered mental status following a fall. She has a history that's notable for hypertension. She'd had a stroke in the last couple of years. She's got some persistent left-sided weakness. She was diagnosed also with Alzheimer's dementia 3 years ago. Recently, her family's been noting a decline in her cognitive ability and her functional status. She seems more forgetful, a bit repetitive. Her hygiene's not quite it was. Her diet's not as good. She's not cooking the way she used to. She doesn't seem to be keeping up with her housework, and they're noticing some errors with her bill paying and just managing of her finances. So now that she's in the hospital, she's stable now. We're starting to do the work that you all do, which is to plan for her discharge. And folks are feeling pretty worried that she's just we may have come to this point now where she's just not safe home alone any longer. This isn't a good idea. And she has a progressive disease, her dementia. This is not going to be fixable, so to speak. It is terminal. It will continue to progress. We're already starting to see signs of the progression with her decline, and they're really recommending some sort of long-term care assisted living kind of setting for her. She, however, has very different ideas. I'm sure this is not unfamiliar to any of you. She is definitely totally committed to going back home. And the more people press about trying to persuade and convince her of the benefits of a different setting, the more agitated she becomes. And so now she's really kind of fed up with everyone. She's intermittently declining medications. She's, when PT and OT come to work with her, she's kind of like, yeah, not today. I'm not in the mood. I'm not doing it. So now we're kind of, here we are, right? A situation you all deal with every day. I would just invite you to share, what are you worried about most right now with her? And what are your thoughts certainly around, where do we go from here? We've got a little bit of a knocking of heads, so to speak, where we have an idea. She's not too keen on that idea. What do you guys think? I see. Is someone going to read me the Q&A, or do I have to do that?
We can read it
that would be awesome.
If you want us to. Yep. So
that would be great. Then I don't have to keep navigating my mouse everywhere.
Yep. We have one response that said assisted living.
So she doesn't want to go.
Someone asked, what are her resources to remain at home? Another person said concern about future decline in function and safety, possible discharge to a SNF. And there's
Yep.
also a suggestion of holding a family team meeting. Safety first and patient choice and voice is second.
All right, so these are all great comments, I think. And is there another one that just popped in?
If she allows start to involve any family or friends.
Okay.
And another comment said if the patient is clear, sound mind, then she has her rights.
Ah, here we are. So what you're all talking about has to do with how do we decide who makes this decision, right? I mean, she's telling us what she wants to do. And I think someone already commented that, you know, if she's clear in her thinking, she gets to decide, right? She has rights. Others are saying safety first. Safety first, we can't just let her go the way she is. So let's just think a little bit about what are the standards we're obligated to from an ethics perspective when it comes to decision-making. And as you'll see on this the top of the line there, autonomous decision-making is really the gold standard. It's what we're always striving for. People have the right to make decisions consistent with their goals and values. And when they have the ability and the capacity to do that, we let them make those choices. If they can't, if we think there's an impairment or they're not able to make decisions, then what do? We've got to look to other people, right? We have to say like, okay, she can't do it, so who's going to do it in her stead? So this is where we start to unpack, is there some advanced care planning document in place? Has she named someone? In Vermont, we call it a healthcare agent. In other states, it's a healthcare proxy, durable power of attorney for healthcare. It's all kind of the same thing. It's the who gets to make decisions if this individual can't make decisions for themselves, and have they named somebody in advance, which we all hope they had, especially since we know she was diagnosed with Alzheimer's 3 years ago. And we would hope that someone would have had the foresight and her medical team to say, gee, her capacity to make decisions going to decline. Let's do some proactive planning here to make sure when that happens, we've got a good team in place. So we want to know the answer to that. And then that person or people, depending on how she's structured it, if she's done any planning, really are obligated to make decisions based on this standard we call substituted judgment. That's based on knowledge of the individual's goals, values, beliefs, preferences, and priorities. Like, what do we know about how she makes decisions? How she's made decisions in the past? What is most important to her? And can we promote her to achieve those goals, even if we, as her decision makers, may not totally be on board? If this is the way she wants to do things, we have obligations to try to make that happen. If we have no idea, then we default to sort of this third line of decision making, which is best interest. Best interest often is predicated on the clinical realities, right? And the proportionality of benefits to burdens, right? Whatever it is the decision is, we have to kind of weigh the good that we're doing against the harm that we're maybe creating. And we know that most everything in clinical medicine is kind of a double-edged sword, right? It's never all just good. There's usually some sort of risk that we need to balance. So when we're doing that, we're trying proportionally to make sure that whatever we're doing, the good far outweighs the bad. So that's the goal. That's how we're going to try to make decisions if we don't think she can make decisions for herself. But then that sort of begs the question about, can she make decisions for herself? We know she has a diagnosis of Alzheimer's dementia. That in and of itself does not mean she can't make decisions. She's been living independently, but we're seeing some signs that maybe she's not as sharp as she once was, and the disease is starting to march along. A few things to think about when it comes to capacity. One is it's presumed. People don't have to prove it. We assume, benefit of the doubt, you have it when you walk in the door. It's also decision specific. So when we say someone has or lacks capacity, what we're talking about is for what decision. It's usually not this global, it isn't a global phenomenon unless the person's unconscious or in a coma, then they literally lack capacity for all decisions. But it operates a little bit differently, and we need to talk about, does she have capacity for the decision at hand? Can she make a plan for being home alone? Can she participate in that plan? So maybe she can make some decisions, but not others. And so we need to be mindful of that. And also the fact that if we're unsure, that uncertainty we manage not in the direction of her impairment or potential impairment, but we manage it in the direction of the presumption, which is she has capacity. So I think it's important to think about, so capacity is sort of at the crux, I think, in many respects of this case. Can she make this decision or not? And how do we know? And I think so often in healthcare, critical decisions really hinge on the evaluation of someone's capacity. Because we know that a person who has capacity, they can leave AMA if they want to. They can say, yeah, thanks, I appreciate your recommendations, but not interested. That happens all the time. This right to say no and to leave when you have capacity is kind of protected by this common law approach, which is also now federal law, which is patient self-determination. But it's not totally clear, I don't think, certainly not in Vermont and not in any state that I'm aware of. What do we do with patients who lack capacity due to a cognitive impairment like delirium, but they're medically stable? What do we do with those people? We can't just incarcerate them in the hospital because they have rights, as someone mentioned earlier in the Q&A. So this is where I think it starts to get complicated, and frequently this is when I get calls as an ethicist to help kind of figure out, what do we do now? I want to talk a little bit about the distinction between competence and capacity. And this is something that I encounter a lot, and I think it's used, these terms are frequently used interchangeably, but they're not the same thing. So competence is determined by a judge. It's a legal term, and the courts decide whether someone's competent or incompetent. Capacity, on the other hand, is a medical term. It's a clinical term. It's determined by a clinician. In Vermont, that's someone who has the, within their scope of practice, the ability to obtain informed consent. So this would fall to nurse practitioners, PAs, and physicians in my state. And I think it varies from state to state. But certainly informally, I think all of us who work with patients and families are assessing people's capacity and you guys are doing it all the time as you're having conversations with people and really getting a sense of how much are they really understanding about their situation. But the formal assessment is typically done by a provider that has within their scope of practice the ability to obtain informed consent. Competence is global. You have it or you don't. And the judge determines this person is incompetent to make whatever decisions we're talking about. Could be medical, could be financial, could be all of it. And so that gets determined typically in a guardianship proceeding where someone's coming and saying this person is not safe, they can't make decisions for themselves any longer. And when the court is naming a person who will be that individual's decision maker moving forward. And they should be crafting that decision-making person in the least restrictive environment, which is why we tend to see that guardians don't always have full powers. It may be carved out specific to the needs of the individual, as it should be, as we think back to that gold standard of promoting and protecting an individual's right to be autonomous and make their own decisions. Capacity, on the other hand, operates more on this kind of sliding scale, right? It's decision specific, as I said earlier. So we need to talk about what's the decision and how much capacity is really needed to make that decision. So we think about it sort of in terms of levels. At the base of the pyramid, it's probably the lowest level of capacity needed. Can they just express a choice? So people with profound cognitive impairment, they can say yes or no. They can let you know, even if they're nonverbal, how they're feeling in the moment about whatever's being discussed or asked of them. And then as you move up the pyramid, right, you need more capacity. So can they understand, not just express a choice, yes or no, chocolate or vanilla ice cream? Can they start to understand the situation and the consequences of their situation? Can they take in the relevant information, reason through it in a rational way, appreciate the difference, the benefits and the risks related to their situation, and then make an informed choice, right? Are they able to do all of those things? Pay attention, absorb the information that's presented to them, think about what's happening now and apply that to the likely future consequences, which is kind of what we're going to need her to do in order for her to be able to, for us to feel confident that she can go home. Can she actually appreciate the fact that it could happen, like what we're talking about, these risks, not just in the abstract and parroting back what we're saying? Can she appreciate that the consequences of some of these choices, the negative consequences, could actually happen to her, and then reach a judgment as to whether or not she's willing to accept the risks of those consequences? And I think the other piece about choice is that it really needs to be voluntary, right? She needs to be making this decision of her own choosing, not with the pressure or force of someone else telling her she must do it a certain way. So when we think about it in clinical decision-making, capacity, the more capacity is required, the more complex the decision is, the more serious the consequences of that decision, and the more worried we are when the decision seems so irrational relative to what we're talking about. We often, and we don't push very hard to make people prove their capacity when a decision is simple, when the risk is low, when most other people would decide similarly. And I would add to that list when they're going along with medical recommendations. We don't tend to question people's capacity when they're agreeing with us. When they're agreeing to the recommended plan, we don't tend to think twice about whether or not they have capacity. Oftentimes, when people push back against our medical recommendations, it's when we start to think, maybe they don't have capacity to make this decision because they should be doing what we're recommending. And I'll just pause there for a second. Does anyone have any thoughts or questions about this notion of capacity, how it relates to competence, and even to some degree how it relates to this case?
There's one comment that this slide articulates or describes the levels of consideration for family and providers, and thank you. Accurately describes. And someone asked, what does DMC stand for? Oh,
I'm sorry, decision-making capacity.
Thank you.
I thought I had it on the previous slide. Sorry about that. So interestingly, as we're thinking about capacity, it's directly tied to informed consent, right? And so these are the components of capacity. They're also the 4 key elements of consent. So clinicians who have within their scope of practice to obtain consent for treatment have to go through this process of assessing someone's understanding of the situation, their appreciation that these are the facts and this could happen to me, then being able to reason through the options and the alternatives, and then express that voluntary choice. I love this chart. It's an older chart from Applebaum. He's sort of like the grandfather of decision-making and a capacity assessment. And it really does provide kind of a practical tool, if you will, for how do we go about assessing this. And it gives here like sort of questions that you can ask to try to dive a little deeper into these 4 key elements, right? The patient needs to clearly indicate yes or no. The clinician's approach is really to ask them about what do you think, and they give you some questions. Have you decided to follow the recommendations? Can you tell me what your decision is? What is making it hard for you? If they can't decide, why is that hard? And so then they talk a little bit about frequent refusals of choice, maybe because of psychiatric or neurologic conditions, and it could indicate a level of where their level of capacity is. The ability to understand information, and I think this gets at sort of the questions you can ask. Tell me in your own words, because we're not looking for people to just parrot back what the clinician said. Can you tell me what you understand about your illness? Or what did the doctor say to you about what's going on with your health right now? What were the treatments that they recommended? Can you recall the benefits and risks, and asking them those kinds of questions. And then again, what do you believe is actually wrong? And this is where they're trying to take the information we're telling them based on the medical facts and actually apply it to their own situation. Do you believe you need some treatment for what's wrong with you right now? Why is it? Do you think? I had a case recently of an individual with severe anorexia, and I went to meet with the patient. And the patient was very weak. And I asked, why do you think you're as weak as you are? And the response was, I have some health issues. And I said, well, can you tell me more about your health issues? Right. And it took a while, but ultimately there was acknowledgement that it's probably because I'm not eating enough. Right. So there wasn't eventually the patient kind of got around to recognizing that lack of nutritional intake was actually contributing to the weakness. But initially was not really too open to go there. Everyone was thinking that the person didn't have capacity. And I actually think they definitely had capacity. It was really more a function of the profound mental health problem that was really interfering with a fixed belief or misperception about body and food. This is a nice tool, I think, to give you some real language, if you will, to start to think about how do we tease out someone's understanding of their situation and their ability to really manipulate that information in a way that they can make actually an informed decision. So if someone lacks capacity though, and they want to leave AMA, so let's just say we've assessed this person and people are like, I don't really think she's getting it. I don't think she really understands what's going on. And she really is committed to leaving, and clearly she can get up and walk out. I mean, it's not like she's mobile, she's ambulatory. It's not like she needs our assistance. But we think there are pretty big risks to her going. What are the options? What can we do? Do we just let her go? AMA, that's one option. We could request a psych evaluation and have psychiatry, who frequently, I think we look to psychiatrists as our experts in assessing capacity. And these are a couple of tools that they may use to do, or any physician actually, or clinician can do it. But I think we often seek psychiatric assessment, and we might even think, is there a way that we could invoke an involuntary psychiatric hold? In Vermont, we would call that an emergency evaluation, where you can, due to a mental illness, if they qualify, you can hold somebody for up to 72 hours. I think all states have, I know all states have that type of a provision in their law. So you could see if psychiatry might be willing to evaluate this person and invoke a hold, or you just detain them. You just actually don't let them go. Right. So what do you guys think about those options? Anybody feeling like it would be a bad idea to call psychiatry? Maybe other people are thinking, we should just let her go, set up some home health and hope for the best, even though we know she'll probably be back. And others might say, yeah, we're just not going to let her go. We're just going to say she lacks the capacity to leave AMA. And I will say I see this frequently written in charts when ethics gets called on these kinds of cases, where there's a note that says patient lacks capacity to leave AMA, don't let them leave. What do you guys think about that? And I'd be interested to know how this kind of those options get addressed in your different settings.
First question or comment is, I question if that is legal.
The just holding them or letting them go?
I believe, I'm not sure. Marion, if you would clarify what you're asking. Another comment says our PCPs are very slow to make decisions of capacity. Oh, and Marion clarified, she said holding them. She questions if that's legal.
Yeah, that's a good question. I can tell you in Vermont, it's not legal. We have no legal mechanism to do it in Vermont. And we can talk a little bit about that later. And there's kind of a dearth of information, quite frankly, and I'll talk about it in a little bit. There isn't a lot out there about medically holding people who are medically stable, but so they don't actually need to be in the hospital for medical reasons. But they have some impairments to their capacity. There's not a lot of tools out there to hold them, except for your exceptional tools of respectful persuasion, which we rely on heavily. But there is some legal issues around just holding people. But I will say I see it happen all the time. We just hold people and say we see a note in a chart that says you just can't let them go.
Right. Couple of other comments. I think the MMSE and the MOCA are good to do to back up a reason to hold a patient. And another comment, start with determination of health if healthcare proxy and have MMSE completed.
All right, so let's unpack that a little bit more and we'll get a little more information on our case. So you guys who are always I think at least in the hospital I work at, and I actually co-chair another hospital ethics committee as well, but we rely heavily on your super sleuthing skills to try to figure out who are the people in these individuals' lives and what do we know about any planning. So unfortunately, although I would say not uncommonly, there are no advanced care planning documents that we can find for this individual. So we don't seem to have an advanced directive or anything. Psychiatry, someone did say, let's just get a psych consult. And she's got a MOCA of 16. So not surprising, right? That's, if you look, I think on the scale, 16 is indicative, if you're of an Alzheimer's type dementia, but we knew that she had that. So yep, she's got some impairments. That not a huge surprise, but not hugely like she absolutely can't make decisions. She continues to maintain her refusal about long-term care. And she's intermittently not taking her meds because she's mad, she's angry, she's frustrated. And she's just done with PTOT coming in here and everybody kind of badgering her about, what she needs to do and that they want her to go to long-term care. Interestingly, this sort of estranged daughter has shown up. She's resurfaced after not a lot of contact with the family for the last 20 years. She's quite outraged that no one's been taking better care of her mom, and now she's in the hospital, and goodness me, what's going on? So she offers, I'll move in. I'll go and live with mom. But she's insisting that she wants her mother to appoint her power of attorney for not just the financial decisions, but also for healthcare. She wants all the power to make decisions. Mom now is hugely happy to see her daughter, which she hasn't seen in quite a while. And she completely agrees. This is a great plan. I'm going to go home, and my daughter, who I haven't seen for a while, we're going to reconnect and we're going to be back together. Well, there's 2 other adult children, and they're absolutely like, this is not a plan. They tell the staff, listen, the reason we haven't seen our sister for the last 20 years is because she stole thousands of dollars from our parents. Clearly, mom is not remembering any of this due to her disease process. She's just so happy to see her. She's unemployed. We think she's homeless, and we are pretty sure she has a substance misuse problem. So there is no way you can discharge her back home with this as the plan. Absolutely not happening. Terrible idea. Now what do we do? Where do we go from here? Because originally I'm thinking great family involvement, someone stepping up to the plate. This is just what we like to see. Somebody willing to take on some responsibility here. And now we've got family who, when crisis arises, I'm not sure about in your setting, but it seems in the settings I work in, that's not really when dysfunction becomes functional. All of a sudden now we've got everybody fighting. So what do we do about this? What are you guys worried about now? And what are you thinking your next steps might be in terms of trying to resolve this?
A couple of comments. Consult the courts for guardianship, consult hospital legal, and confirm that there is no healthcare proxy.
Okay, well, we know there's no legally appointed healthcare proxy. Consulting the courts on the list of options for sure. Do we need a guardian? Are we there yet? Will this patient present as incompetent to make all of her decisions? And I think this is where knowing your local court system is a good thing in your local state. I can say that in Vermont prioritizes patients' right to self-determination almost to the extreme. And I would say in many instances, clinicians scratching their head, thinking, clearly this is a bad idea. Autonomy is not the only important factor that we need to think about, but Vermont has a pretty long and steadfast history of really prioritizing people's right to make poor decisions, often even when we can foresee that things are not going to go well and they'll be back with us. So I want to talk a little bit about these sort of ethical obligations around this, because this is clearly not a cut and dry situation, right? She doesn't completely lack capacity, but she clearly has some impairments. She's not functioning 100%, right, in terms of her ability to make decisions. That being said, it's not absent, right? I mean, she's talking with us. She's saying this, I want to go home. I now have a daughter. She can look after me. She's kind of making some sense. Even families thinking, no, I don't think this is a good idea. Just think a little bit about autonomy, because I think that I get calls all the time and people saying, well, we have to respect their autonomy, and we do, but there are limits, right? So generally, when we think about autonomy, this idea of being self-governing, right, it makes us think about self-determination, which of course we know is a right that everyone has. Being independent, being free, being voluntary, making your own choices. We have obligations for sure to support people to make as many decisions as their capacity allows, and to do that in the least restrictive way possible. People have the right to make bad decisions, and we need to let them. It's hard to do, especially when we have obligations that counterbalance this autonomy that we'll talk about. But it isn't absolute. I had a call just yesterday and about someone's autonomy, which was including harassing the medical staff. And I said, well, we can constrain people's autonomy justifiably from an ethics perspective, certainly for a bunch of reasons. If they lack capacity, we can actually infringe on sort of some of their freedoms to keep them safe, which I think someone mentioned early on. We can infringe on people's autonomy when there is opposing needs that benefit individuals and society at large. And we're seeing this now in the midst of a pandemic, right? Autonomy isn't ruling the day when we have a public health emergency, right? We may be, if we're dealing with issues of capacity or scarce resources, prioritizing the good of all over the good of the one. And that is a difficult construct, I think, in the United States for people to wrap their brains around, because it's just not normally how things are done. We almost always default to people's ability to make decisions for themselves, and we rarely are infringing on that. And so a public health crisis like a pandemic certainly has made people begin to appreciate this other obligation to the public at large, which is hard. It's hard to do because it's so foreign to what we are normally experiencing, certainly in healthcare. And
Cindy,
also,
just a
yes.
question about the case that you were talking about. Why aren't the other children stepping up?
Yeah, they want her to go to long-term care. They do not see that they are going to be able to, they have kids of their own, they're busy, they work, they don't believe they're going to be able to take on the responsibility of managing her day-to-day needs as she declines. And they think a long-term care, they're totally on board with the long-term care solution that the hospital has initially proposed. They think it's a good idea. In fact, they thought it was a good idea a couple of years ago, sort of proactively, but mom wasn't ready to go. And so now this is they're kind of holding hard and fast with the idea that she should go to long-term care and trying to figure out how to make that happen. And then, so individuals aren't free to basically violate other people's autonomy. So kind of that, you can swing your arms until you hit someone else in the face and then it becomes a problem. You don't get to consume all of the resources for yourself when there's other people, say in the hospital, who are also entitled to have good care. And so there are times where we don't do everything that people want because we can't, and that's okay. And it's ethically and legally defensible. And autonomy can be reasonably and legally restricted when it collides, so to speak, with some of these other duties and rights and interests. So autonomy is important, but it's not the only ethical consideration that is at play. We also need to think about our beneficence-based responsibilities, right? So we have obligations, equal obligations, not just to respect autonomy, but also to promote and restore wellness when we can, to protect the health-related interests of patients, to avoid foreseeable or disproportionate harms, and that's the principle of non-maleficence. So those are beneficence and non-maleficence are two sides of the same ethical coin, so to speak. So we got to do good for our patients and try to avoid harm, particularly when it's disproportionate. It also includes being beneficent, also includes the responsibility to respect the patient who has impairments as a person. So we can't treat her as an object to do with as we please. Understanding that she still has some autonomy. It's an important ethical consideration that we need to keep in mind, and we can't overburden it, so to speak, by really intruding too far. So when capacity is impaired or lacking, we also still have the obligation to seek the patient's assent. Maybe she can't consent because maybe her capacity is limited to a degree that she's not really able to appreciate the risks that she's undertaking, but we need her to at least agree or at least not say no. So interestingly, this idea of refusals, I think that's probably the number one most frequent question I get or have gotten in the last year, and our team certainly at UVM when it comes to ethics consults. What do we do when people just say no, not doing it? How far do we always have to respect their refusal? When can we treat them over their objection or do things that are in their best interest, even if they're not in agreement? And this brings up the idea of negative and positive rights. So individuals have the right to refuse. That is a fundamental right, and it's a negative right. It's considered the right of non-interference, to be free from unwanted medical interventions or bodily invasions. It's the right to your bodily integrity. So even people who lack capacity retain the right to their bodily integrity. And that's sort of that minimizing the burdens placed on their autonomy. You can't just do things to them because you know it will benefit them if they are actively saying no. Now, if they're just agreeing, that's assent, right? Not consent. And so we tend to, if they're agreeing and going along, we sort of act as if, and we do things that are promoting their health-related interests as part of our beneficent-based obligations. But when they put up the wall of the no, don't touch me, I'm not taking that medicine, get out of my room, I'm not doing PT today, we then are in the position of having to acknowledge and honor that negative right that's fundamental that everybody has. It's really different though, because I think people try to invoke the same kind of thing on the positive side, which is, you must give me this, you must do these things, I want this, therefore you have to deliver it. And so we do have obligations to give people the option to choose amongst medically feasible options as a positive right, but there is actually no equivalent positive right to demand treatment or any procedures that are not medically indicated or are considered non-beneficial or inappropriate. So we don't have to do things just because people ask us to. So there is this professional responsibility, if you will, to set appropriate limits on when it makes sense to provide certain treatments or medications, and when we say no, we don't have to. So I think sometimes people conflate negative and positive rights as meaning, well, they've asked us to do it, so we have to do it. No, we don't. But when they do refuse, actually, we can't interfere unless it's an emergency. And that seems to be kind of a legal framework, certainly in Vermont. And from what I can tell, it's pretty similar across the country. So in Vermont, we've baked it into our advanced directive law that says when patients lack capacity, the law reflects the ethics here. They retain the right to refuse. So in Vermont, our law says that it respects the negative right to bodily integrity, even when someone lacks capacity. And there are only two exceptions to when you can intrude on that. One is if someone has completed an advanced directive that contains a provision, we call it a Ulysses Clause informally, but it's really a provision that where they, in a time of capacity, waive their right to refuse later. So they say, listen, I'm telling you now of sound mind, if I say no later, ignore me and treat me over my objection anyway. So people can do that. They don't do it that frequently. It was typically put in Vermont law for people, I think it was intended for people with psychiatric illness who could foresee that they might stop taking their psychiatric medications and therefore would end up refusing something that at a time of illness, that if they were well, they would never refuse. And this would allow you to treat them over their objection. It's used more frequently, I would say right now, for people with dementia. I've actually seen it used before Vermont had passed our law for medical aid in dying. We saw some folks using it as a way to force no spoon feeding. So people were using it as a way to say, even if I'm requesting food and I'm at the end stage of my dementia, you can't feed me. So it was an interesting use of that provision. The other provision is actually baked into our statutes, also in the advanced directive law, which says healthcare shall not be given to a patient over their objection unless they lack capacity and will suffer serious and irreversible bodily injury or death if the healthcare is not provided within 24 hours. So it's an emergency, or if they've already planned for this kind of a refusal. Those are the only instances in which you can treat someone medically over their objection. The same is true in a psychiatric context, as far as I can tell, for all states. They all have civil commitment laws for involuntarily detaining patients who are a danger to self or others due to a mental illness. So that's the caveat. The reason for their refusals has to be related to a mental illness. So this is where psychiatry comes in, right? They have to say that the reason they're doing this is because they have an actual mental illness, and that's the cause. And so then you can detain them and they would meet that involuntary hold criteria. Very few states actually have laws that address holding a medically incapacitated patient. I was doing a literature research, and what I found was Virginia. They do have something for a temporary medical hold order. That's what it's called, a temporary medical hold order. But there's been a bit of work out of someone out in California at UCLA who's looking at, should we have policies within hospitals for, a time-limited medical hold, because there is no legal framework to do it, utilizing kind of the ethics principles around that. So I'm not sure. It's a difficult situation. So it gets back to, I think, the person's prior comment, legally, can we do it? In Vermont, you can't do it. You can't just hold them if they're committed to leaving. Now, I would argue as an ethicist, you don't have to help them leave. If they can't get up on their own 2 feet and get out the door, we don't have to promote them to do something that's contrary to their health-related interests, but we can't stand in their way. So if they can actuate a plan to leave, then we'd have a very difficult time, basically illegally detaining them in the hospital. So this brings us back to, we're still kind of unsure what to do with this person. And so now it really becomes a function of risk, all kinds of risks. Can she go home with this daughter who seems to be stepping up at a good time when the other siblings can't do it? Is she a bad actor? Is she looking for some secondary gain here? I'm not really sure. We don't really know. So how do we start to think about, there's a lot of risks here for this lady. This question is so frequent, it's prompted me to think more about the dignity of risk and what that actually means. So there was an article back in the 70s, and this grew out of folks who have developmental disability, that there is such a thing as human dignity and risk. And there can be dehumanizing indignity in safety. And I've heard a few people say, we can keep people so safe they're miserable. And that I think is true. So the dignity of risk it has an ethical basis, right? It's about valuing respect for persons, this autonomy-based principle, valuing the right to self-determination and acknowledging that every human decision has elements of risk, and there's a potential that the choices we make will fail. It's a little bit different than therapeutic risk, which we hear, I think, sometimes used somewhat interchangeably, which has more of a clinical focus rather than an ethical focus, where we're looking at risk sort of with potentially positive health and well-being outcomes. that can arise from taking risks. A sense of well-being, this idea of freedom, of promoting hope, a social inclusion, that's how it grew. A sense of identity by being able to make decisions that promotes someone's well-being. And so how do we then approach risk? What are the ways we can think about approaching it? There is clearly a tension between a duty to care and protecting people from harm, while simultaneously upholding their right to make their own decisions, even if we think they're bad ones. And so I think there's some approaches, and we've kind of talked about it at the very beginning. So better safe than sorry. We just need to try to eliminate risk. And this would include, I think, the perception that towards being quite risk averse. And sometimes we may actually be overestimating the actual risks, right? And I think oftentimes in the healthcare field, we're looking at risk through that clinical lens, right? And we're thinking, gee, this is a bad idea. And we tend to try to stay away from those things. But obviously risk it can encompass a much broader range of individual and external factors that we need to take into account. We also may approach risk sort of more from the sort of rights and responsibilities, just acknowledging that there's inherent tension, but we lean more towards the paternalism side, just like avoiding it. And we may not be thinking about the positive side of enabling someone's autonomy, and that maybe by being too risk averse or avoidance of risk, we may be causing some silent harms where people feel somewhat dehumanized. They don't feel like they're in control of themselves, and that maybe is a harm that we need to think about, and maybe in a different way. Not just the harm of a risk of falling, but the harm of what does this do to this person's sense of self when we eliminate their ability to make choices and to take risks the way you and I take every single day when we get behind the wheel of a car, when we, for me, I go out to my barn and I'm walking on the ice, whatever it is. I think the geography of risk is where the risk is happening. And this, I think, comes up a lot with discharge decisions, right? It's sort of when the decision to go home kind of conflicts with the choice to, the recommendation to go to long-term care. But I think one of the things we need to think about is choices as simple as when I get up, what I want to eat, who I spend my time with. When those things get taken away, those are those silent harms that I think we may not think about a lot when we're thinking about geography. We're thinking about where they're going to be most safe, but there are other components to that maybe are undermining that person's sense of well-being and sense of control over themselves. Also, I think the oversight that we provide in a hospital is completely appropriate for the hospital setting, but it may not be the appropriate amount of oversight in a community setting. And so sometimes people's identity also is quite tied to where they are, their neighbors, their friends, who's around them. And that can be really important, I think, particularly for people with dementia. The sense of knowledge about their surroundings may actually be helpful, even though there are some harms around it. So geography is another piece that we need to think about when we're approaching risk. And then also clearly shared decision-making. And this is probably the gold standard, of course. It focuses on how do we negotiate positive risk-taking? How do we do some negotiated risk? This allows for, I think, good communication. And also, I think, to the degree that we're worried about liability, which I know comes up certainly in the settings that I work in, having this kind of shared decision-making conversation can help to clarify lines of accountability, who's responsible, that kind of thing. So it's clear at the outset, everyone understands going in where the risks are and where the decisions are. I guess I would just say I'm basically at the end here, which is good timing. It leaves us a couple extra minutes. So I'm beginning to rethink the way I view risk, certainly as I'm working with more and more people who are aging. Obviously, we're all aging. Dementia is on the rise, and dementia-related disorders are on the rise. And so how do we think about risk maybe a little differently? Because we actually now, I think in the midst of a pandemic, we don't have the luxury of socially admitting people to facilities any longer. We need those beds for acute medical care. And so how do we work with our community partners and think a little bit differently about acknowledging risk, reframing risk, and allowing for risk in a way that promotes that recognizes that there are some positive aspects of risk taking that we may not have always been paying close attention to in our efforts to help people. And again, I don't think anyone's doing, making decisions or making recommendations in a way, thinking of trying to be punitive in any way. I think it's all comes from a beneficent place, but we might need to expand our view of how these risks are unfolding. So appreciating the medical versus the social and personal risks, considering risks of going home compared to risks of institutionalization, that idea of being socially isolated away from people that you know, and the emotional toll of that, depression, people feeling a lack of agency because those simple decisions like when I get up, what I eat, what I do, who I do it with, have been removed. Looking at risk in a low versus moderate versus high risk and trying to distinguish between what is an unwise decision versus a truly unsafe decision. Recognizing the positive aspects of risk. Not all risks are negative and potentially harmful. We can promote hope and empowerment, personal responsibility, social inclusion, and then consider it as a spectrum, not just a binary good, bad risk kind of a thing, but there's a spectrum. And maybe we start to think about time-limited trials. Like, let's give it a try. She's been at home all this time, and this is the first time she's truly failed. So do we go with our most restrictive recommendation, or do we try to find a middle ground? And maybe there's a time-limited trial where we bolster some community support. She hadn't been receiving a lot of home support. She hadn't needed them, but now she does. What do we think about this sister? Is she a bad actor? Could be, maybe not though. Maybe she's, lots of people change. It's been a number of years. Maybe her reasons for doing this are she feels bad about what has happened in the past and she's looking. We could get more supports in the home so we have more eyes on. And talk with those siblings who don't like the idea of the sister, but maybe this is an opportunity. So again, these are all ways to reframe risk and think about it. But I would argue that I'm certainly not an expert in how to do this on a day-to-day basis. You guys are doing it all the time, but I do think it warrants maybe thinking about it a little bit differently and recognizing these inherent tensions, and also that the law in most states really doesn't give us the tools that we're looking for if they don't meet EE criteria. And I will say, in the instances where psych has done evaluations, certainly in the hospital that I work in, and written in the chart, lacks capacity to leave AMA, do not let leave. We've pushed back and said, do they meet EE criteria? Because we can't just hold them medically. And unless they're willing to do the EE, which most dementia patients won't meet that standard because they don't have a mental illness. Dementia is not a mental illness. So then we have to say there's no medical hold. We can't just do it. We've got to come up with a different plan.
Cindy, we do have
go ahead. Yeah.
A comment, and it's actually related to a comment we had earlier that I didn't bring up, but Amy is asking, what is the barrier to the PCP addressing these concerns with patients ahead of time in the community so that it's not always an acute or emergent situation? It's very frustrating. And earlier we had a comment when you were asking about what do we do with this patient who was refusing care, even though the majority of her family was wanting her to go, and she did not have an advance directive. Do you go back to the PCP to see if they've had a conversation about what their wishes would be?
Yeah, and I think all of those are, and I think that's all I think what a lot of times you guys are doing, and certainly we're doing in ethics as well, is we're going back to the people who've had and looking through the chart and contacting the PCP to see what kind of conversations have been had. I don't know what the answer is. In my Vermont Ethics Network role, a large part of my work across the state is on advanced care planning and preventive ethics, if you will, which is why must we use management by crisis as the preferred method for decision making, when we know there are tools out there that would help us do this in a far less stressful way. And if anybody knows the magic bullet to make that happen, I would love to hear it. I think that there continues to be this just lack of comfort. I don't know whether people are too busy. They don't feel like they have the communication skills. Often I hear that they're waiting for somebody else to do it. Often the PCP, who we know, they just don't have time. They often don't have time. I mean, this is a function, it's a reality. So I think there needs to be more support community-wide to help people complete these documents in advance. I mean, someone who had a diagnosis of Alzheimer's 3 years ago, I mean, there's no excuse for not bringing up, they're going to lose capacity. I mean, it's a given. It happens. So if you know that, why not start that proactive when a person is of clear mind? Could she name a healthcare agent now? Maybe. Could she still do some advanced care planning? Dementia in and of itself doesn't mean you can't do advanced care planning, because we think back to our levels of capacity. Who do you trust to make decisions for you if something unexpected happens? That's not a really complicated decision, right? That's not a high risk, high stakes, complicated decision generally. And so we should be promoting people, even people who've had maybe an exacerbation of their underlying dementia, if we haven't done it earlier, to say, gee, if this happens again, is there someone that you would definitely want us to be working with to make decisions while we're trying to get you better? I mean, there's a way to frame it. It doesn't always have to be around dying. And I would say that that's probably the one misstep in the whole kind of self-determination, advanced directive, advanced care planning movement that, I mean, hindsight's 2020, right? But when you connected it directly to death, and we're a pretty death-averse society, nobody wants to talk about it. But if you frame it around, hey, unexpected things happen. And while we're working to get you better, who are the people that you want us working with, who know you best and who can help us take good care of you in a way that reflects what's most important to you? That becomes a much easier conversation. And let's not talk about code status and feeding tubes and the things that make people scared. Let's just talk about, who do you trust to make decisions, and get that one, kind of buttoned up. And from there, as people age, as they develop some, crises happen, and it informs them. Then we can start to talk about the what's most important. What are the trade-offs you may or may not be willing to make? And I think that, for some people, they'd rather live a shorter amount of time if they're doing it on their own terms in their own setting. And that's okay. And knowing that ahead of time is helpful, because it creates, I think, more realistic expectations, and everybody can get on the same page sooner. But I don't know the solution. And I agree with you. I think it's very frustrating when people don't, when we see in hindsight the missed opportunity to do some good planning that really could have averted a contentious situation. That's tough.
Yeah, a couple of comments, and actually, my own experience with advanced directives and having people execute those are the legal departments and the facilities I've worked in have always said that if you are, or at least the impression, that the impression we get is that if you are at the point where you would invoke an advanced directive on a patient and they don't have one, you're beyond the point where you can have them execute one. And that seems to conflict with what you just said. I mean,
well, it might conflict with, it doesn't from a legal perspective, if you're looking at it as very much a have it or don't have it binary competence kind of a viewpoint, it totally makes sense. If you look at it through an ethics lens, where we're talking about something that's not competence, we're talking about decision-specific capacities, and that it's a waxing and waning phenomenon. It's purely about the decision at hand. So does someone have the decision to negotiate a complex surgical procedure with maybe a complicated follow-up and post-operative recovery process? Maybe not. But can they name the person that they would trust to help guide those decisions if they're not able? That's the level of decision and capacity required for those two decisions are not equivalent.
Okay.
And so I think it frames, I think you're looking at it through two different lenses. And I think there is a tendency, certainly even within the legal community, particularly, to view everything through the lens of competence, because that's what they know, that's what they do. But capacity is not the same. And so I think we run the risk of kind of overriding people's right to self-determination in a very parental way when we equate competence and capacity. There are certainly times where someone is incompetent and they lack capacity. Like, I mean, there's just no question. They can't make decisions for themselves. It's the ship has sailed, right? And our opportunity to do advanced care planning and our window to do any of it has clearly passed. And that definitely exists in some situations, but not in all situations. And so we need to think about it, I think, again, in that sort of least restrictive manner. But I'm the ethicist, right? I'm not the lawyer. So you're going to have to negotiate and navigate that within your settings, with your legal risk managers, and within your state laws. But certainly I live in a state where, I mean, people prioritize autonomy sometimes in an inappropriate way. And we have to sort of walk that back as well. But they're different terms.
Great. We have 3 comments. 5 Wishes program is a great community-based resource we should all consider and share. Amy says it creates a very unfair situation for the patient and family when in the acute setting, when the goal is to move them out and discharge them. Thank you so much for the presentation. And Pat says, thank you for addressing completion of healthcare proxy and dementia population proactively. Any other questions or comments you have for Cindy?
And I can stop sharing. Where's my little mouse? Here we go. There we go.
If you have any questions or comments, please put them in now. We've only got a couple of minutes left.